Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Veno-Venous' complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Veno-Venous' range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the Veno-Venous WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Veno-Venous EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
So good. How can you cut them short? Hey, everybody. How are you? Good morning to PerfWeb 49 and Tammy Sparacino Journal Club 11.
Yep.
We're going to have 12 before the end of the year.
We are.
So real quickly, I'll just tell you, December 17th, long-term survival, post-traumatic stress and post-traumatic stress and quality of life post-ECMO. And actually, this article you're going to do today mentions a little bit about post-traumatic stress, as a matter of fact. So the journal today, really interesting. This is going to be one of the best ones I think we've ever done. I read it, was fascinated by it. In fact, I read it 3 or 4 times to really try and absorb it. Great article. But before I get started, I'm going to get in trouble. Our sponsors, LivaNova, Siemens, Houston Extracorporeal Technologies. Social media, Facebook, Twitter, YouTube, LinkedIn, like, follow, share, give us the thumbs up, make sure you subscribe. You got to subscribe, really important. And also click the bell for the notifications so you know when we go live, okay? Websites, go to perfweb.us, which is our schedule. And that'll tell you, and we're going to be doing January's schedule very soon. Give me a couple of more days. We're going to do something really big next year. There's a lot happening. I'm just not ready to put it out there yet. I want to surprise everybody and for some other reasons, but we'll talk about that later. What was the other website? Oh, yeah, you went too fast.
Oh, Perfusion Education.
Yeah, perfusioneducation.com. Yeah, why are you going so fast? Perfusioneducation.com. Go there, and that's our library, and that's where you can become a member. It's free. All of our content is totally free, and will always be completely free. If you need the CEU certificate, then you do pay for it. But we're here to share information openly amongst everybody. And listen, we'd like you guys, if you want to be on the program, I know that's how we got John Ingram. We watched our show. He's on our program today, coming to us from Orlando. There's going to be some new folks. I'm bringing in some new people and stuff to really expand our faculty. If you have an interest in being on the faculty, you can do it via the Skype, or you can come here to the studio. If you happen to be in Houston or traveling here for any reason, we can come there. A lot of options. If you have a particular topic you'd like us to cover, or more on something, or less on something, whatever the case may be, contact at perfusioneducation.com. We will answer your email. When you see this icon, our telephones are open. Love for you to call in, become a part of the discussion if you'd like. And I want to talk to you very quickly about our new app, which is out there, the Critical Care app for perfusionists. So it's critical care and perfusion, but it covers everything perfusion related. ECMO, this is great for perfusionists, ECMO specialists, good for ICU docs. In fact, I had a couple of nurses download it last night. So, you know, people are really excited about this app. It's got a lot of neat features. We certainly will be doing some updates. In fact, one of the things you're talking about today, Tammy, I'm going to do an update on and add it to the app.
Oh,
so we're going to keep developing the app in a very targeted, strategic way with things that we really are going to use, right? But I need to sell 1 million of these things, okay? I don't know exactly where we're at. I don't think we're near 1 million, but we got to sell 1 million of them one at a time. So please get your family and friends, your children, spouses, doesn't make any difference, brothers, sisters. It's like Girl Scout cookies, okay? Everybody needs to have this app, whether they're medicine or not, I don't care. I need to sell 1 million of them. So if you could do that for me, I'd appreciate it. Okay, so with all the frivolity is over, we have to my immediate right, as you all know, Tammy Sparacino, who this program is named after. It was her, essentially her brainchild. She has really taken this to a whole new level. I really find it a very exciting and very informative. I've learned a lot from all of these things, and it's really been exciting for me. And then also coming to us from Orlando, Florida, is the ECMO perfusionist specialist extraordinaire, John Ingram. He has 16 ECMOs that he's 18 ECMOs that he is managing at one time. Now they have ECMO specialists, so he's the ECMO specialists are at the bedside. John is the perfusionist who basically is there as the resource, or if anything needs to happen, he's there to take care of that, which I think that type of blended program is the best program that you can have for ECMO. I frankly don't think that the way we're doing it is sustainable, but that's another discussion for another day. I was up all night taking care of a patient, and I'm going to, in fact, probably refer to it after you've had a chance to describe this, because I think there's some very stark differences in what these folks did and what we're doing, but I think that'll be very interesting. And then John has got some great insight on this as well. But the title of this is VV ECMO, and for respiratory failure, specifically, how long is too long? It's a very, very, very controversial subject, and it's also comes with tremendous ethical dilemmas associated with it. Again, also elucidated in this article. Listen, I'm probably belaboring the point. Tammy Sparacino, she has the article. I think this is going to be very interesting, and I'm looking forward to hearing it. So please, the floor is yours.
Okay, thanks. Good morning, John. Thanks for joining us. Thanks to everyone for joining us as well. So Joe introduced the article. This was published in February 2019 in ASIO. You see the title there is Veno-Venous Extracorporeal Membrane Oxygenation for Respiratory Failure. How long is too long? It's by Jay Menaker, and he's out of the University of Maryland Medical Center.
Yeah, it's a big time place. I mean, and they're apparently doing a lot of it.
Yeah. All right, so let's go ahead and look at the abstract. I'm not going to go through the abstract. This is an extremely long one, but I'll just touch base, and then we'll kind of break it down into sections. So this was a data collected from August 2014 to February 2017. It's a retrospective study. They basically wanted to look at all the ECMOs that they had for their patients there during that time period, and look at comparing short runs of ECMO versus extended runs, okay? So let's go ahead and just kind of get into it, and we'll talk about the data as we go here. Okay, the reason this paper was published, the significance for the study, was there, up until this particular study, There had been a few very important studies, but they all had mixed results as to were extended ECMOs, did they have the same kind of survivability as shorter ECMO runs? So they thought it was important to try to see if they could determine this. All right, so the problem to be solved is how long is too long? At what point should the ECMO run itself be a decision, help you make a decision as to whether or not you should continue the support? Okay, so it's a retrospective review. It was all VV ECMOs admitted to their lung rescue units at Crowley Shock Trauma Center at the University of Maryland. They included all patients that weren't post-lung transplant, post-cardiac procedures, or a bridge to a lung transplant. So basically, they're looking at viral pneumonia, bacterial pneumonia, aspiration, ARDS, post-trauma, and those sorts of things.
So acute phase
stuff.
ARDS.
Exactly. Okay, so here's their relative guidelines that they used. And you can see that the left column is the indications and the right column contraindications. Do notice that they did not include patients, or it was contraindicated for patients greater than 65 years of age, which I think is something a little bit different than what we're seeing now, at least in Houston anyway.
And when was this done again?
This was collected data from August 2014 to February 2017.
It's fairly contemporary.
Wrote the article in 2018, and then it was published the 1st of 2019, like February. So pretty contemporary article, but still, this is these are the parameters that they were using. Here's their demographics. You can see their average age was 44, BMI 33. They had a range of 27 to 38, BSA 2.1. Their RESP score, which we're going to go over a little bit more, was average of 4. And so on and so on. Average amount of ECMO hours, 309.
Can you go back to that slide?
Yeah, of course.
I just wanted to look at, just very quickly, and can I point something out?
Sure.
That PaO2, FiO2, or otherwise known as PF ratio, of 67 with a range of 54 to 79 is really amazing to me. I think also the 10 days, the previous slide, that they went as long as 10 days. I think my understanding was 7 days, but they went
did
10 days.
Yeah, 10 days or less.
10 days or less, or they were contraindicated 10 days or more. But I'm very interested in the size of their patients, and I'm very interested in this aspect of the ventilatory time on the ventilator, and also on the next slide that you had on the PF ratio being that incredibly low before the decision to put them on ECMO.
These people needed ECMO, but they were very conservative in who they put on by those numbers, I would say.
No question. Yeah. No question.
Yeah, for sure.
Yeah,
I'm sorry.
Can I chime in one thing there too, guys?
Mm-hmm.
Yeah.
So also, notice that their average ventilator day was only 1. I mean, it ranged from 0 to 4, but they really put people on ECMO.
There it is.
Right there at the on that slide, put people on ECMO pretty quick.
Yeah, that's true, and I saw that too, and I meant to mention it, but you're 100% correct. They did not wait. But John, in all seriousness, a PF ratio of a mean of 67. I mean, 150 is a clear indication for ECMO. Under 200 is you should be at 250. You should be at least thinking about it.
And they also had a very, very large BMI average. Isn't that quite extraordinary there on an average BMI, 33?
No, I think that's really low. Can you turn that down just a little bit?
Yeah,
I think that's really, really low. The guy that I did last night had a BMI of, what did I just say, 47?
I think it was 47.
47.3 or something, 47.3. No, I would love to see a patient with a BMI of 33 and a BSA of 2.1.
What, 33? I think that's is that just entering class 2 obesity?
I'm 30.
Yeah, but
You
I'm
know.
just saying, like.
Yes, 30 is the cutoff for obesity.
Yeah.
So technically, I usually just add an inch to my height,
and then you're okay.
I'm 29.5.
Okay.
You know how we are. We'd love to add inches.
Yeah, for sure.
To height.
To height.
Yes.
Don't we? Yes. That's where I was going. Okay. Let's look at this third table that they included in the article. Indications for ECMO. You can see it was viral pneumonia, bacterial pneumonia, aspiration pneumonia. Aspiration and ARDS were their 2 highest categories. They had a total of 139 patients. You can also see that column number 2 is the S ECMO, and that is what they considered short-term ECMO, which was 504 hours or less, which is 21 days, I think.
Is it?
Yeah.
I'll look it up.
I think it's
I'll
around
do
21 days. And then E ECMO, which they only had 31 of those, but that was the greater than 504 hours.
21 days, you're right.
21 days, okay. This is the comparison of the short-term ECMO versus the extended ECMO. And you can see that I think they considered a P of 0.05 to be statistically significant. So not a lot of the variability in some of the things. You can see the average age is almost the same, the BMI almost the same, BSA very close. Even the PF ratios also very close. The rest score also very close, so not a lot of differences there. Now there was a difference significant on the ventilator days. You can see that for the short term, the average was 1. It was 3.5 for the extended. And also, there was one more I was going to point out. And the amount, the percent that were prone, 55 to 30%. Okay, so their conclusions.
So can you go back real quickly?
Sure
So I
thing.
just want to make sure for the viewing audience. So anything that is a p-value of 0.05 or less is statistically significant.
Right.
Anything that is 1 would be completely, by that's then totally
Basically
by
the
chance.
same, yeah.
Right. So the only 2 things that I see on this entire thing, 3 things that are significant are the ventilatory days and their difference of that, ECMO hours, which
of course
one's short, one's extended.
Yeah.
So I expect that, and the patients that were or weren't prone. Everything else is simply not statistically significant. So
Correct.
0.05 is that cutoff for statistical significance.
Correct. Okay, so let's talk a little bit about their conclusions. All right, so actually, let me go back just a little bit before we wrap up to the conclusions. I wanted to talk about the studies that they mentioned that had previously been done and kind of what prompted their interest in doing this. So, as you know, in the 1970s, 1980s, we really didn't have a lot of success with adult ECMO.
No.
It was very unsuccessful.
Very
really,
dismal.
Yeah, the turning point really came around
2009.
Yeah, I was going to say 2009.
H1N1.
The H1N1. And specifically, Australia, New Zealand, and Italy started reporting that around 9-day average ECMO run, and they were having really good success. Now, France also was a part of that outbreak, of course, but they actually had a mean time of about 23 days on VV ECMO, a huge standard deviation. Not really sure, about that, why that happened. Also want to make note that the ELSO has been keeping a registry, and since 2009, the mean time for adult patients on VV ECMO for respiratory failure is around 9 to 10 days, about 260 hours. The longest run, this is, I thought, very interesting, 6,248 hours, 260 days.
That's a long time.
Yeah.
I know that patient didn't survive.
That patient didn't survive. Now, the patient that longest run, according to this article, that did survive to discharge and actually lived 7 months after that and then ended up dying of a complication when they were in rehabilitation, 182 days. That's a long time on ECMO.
That is a long time. Very long time.
ECMO.
And you can't ignore, you also have to mention, I think, and it's in this article as well, but really what launched ECMO, I think the Sentinel article is the Cesar trial.
Right.
And I think that there are some people who have, have said that they think the Cesar trial was flawed as a trial, but that is, I think, the main article that is referenced when somebody is, reviewing whether or not to begin or continue with an ECMO program, because that did demonstrate very good survival benefit.
Correct.
With H1N1 with the use of VV ECMO. John, do you have any other articles that maybe you knew of?
I want to talk about these three real quick, and then I'll let John go. So they talked about, the mixed reviews about extended versus short ECMO runs.
Yes.
And so they referenced three particular articles. One was done in 2011 by Camboni, and it reported that out of 127 patients at more than 4 years of, that required VV ECMO, the authors had three durations: less than 10 days, 10 to 20, and greater than 20. They demonstrated a significant difference in survival for those that were greater than 10 days as opposed to those that were, less than 10 days as opposed to those that were 10 to 20 days. It was a 59% survival rate versus a 31% survival rate, which gave us which gave a p-value of 0.005.
That's significant.
Yeah, that's very significant. Okay, however, there was no survival difference for those less than 10 and those greater, or those in the 10 to 20. Yeah, which is very interesting. Sorry, I said that wrong. There is no difference between the support for less than 10 or 10 to 20, those two, compared to the ones greater than 20.
So this article refutes essentially that article you just mentioned, in that extended ECMO really does not, according to these authors, have a decrease in survivability.
Right. So then in 2015, Kahn did 55 patients, and what they found was no difference in hospital or 30-day mortality between their two groups of long versus short. Lastly, I'm not going to say this name correctly. Magic's saying it perfectly.
Poslusny.
That one. Thank you. He did a retrospective review of ELSO registry and evaluated all the extended ones, and found that greater than or equal to 14 days was the dividing line, and that overall anything was 504 hours, which is what they ended up going with for their long versus short. And despite an increased survival with the ECMO, with the lesser period, that they found that there was lower hospital survival rate compared to those with prior survival rates of short-term ECMO. So you can see there's one that said didn't matter, one that said does matter, another one that said does matter. And so that's what I think really motivated them to try to do this study.
These people, yeah.
Yes, exactly.
Do we have any idea how many ECMOs these people do?
Well,
that wrote this article, the total number of ECMOs that they do.
Let me see if it mentions the exclusion.
I didn't see it.
I didn't see it, but let me just make sure. I know that they're a large ECMO facility. They're a transfer center, is what I understood. Let's see, 180 patients, classified. No, it doesn't say how many were excluded that I see. But that would be interesting to know for sure.
I would like to know that.
I also thought, before we get to the conclusions, is some of the things that they talked about as far as some of their parameters that they follow. They have a very standardized protocol. They run PTTs 45 to 55. They, patients who require prone, they do 8 hours for their initial to see if they can hemodynamically tolerate it. Also to evaluate skin breakdown, and then if they tolerate that, then they go to 16 hours at a time. And let's see, they do. They only try to maintain pulse oxes greater than or equal to 88%.
That's fascinating.
Yep. That they do. They're very specific about their PCO2. 35 to 45 is what they shoot for. However, if there's right ventricular dysfunction, then they do 35 to 40. And then this is something that I thought was interesting. Once decannulated, patients have a planned surveillance at the cannulation sites 24 hours after decannulation for thrombus, for deep vein thrombus. And then if they find anything, then a repeat study is done in 2 weeks. And if there's something there, then they're on treated with therapy for 3 months. So I thought that was pretty interesting.
That is.
Okay.
I don't know that we do that.
No, I don't think we do that. Okay, so let's get to their overall conclusion.
Take your time. Don't get such a rush.
No, I'm not in a rush. There's so much. We could talk about this article
for
a really long time. So in conclusion, they feel their study demonstrates that patients who require VV ECMO for ARDS or ARF have similar survival rates to those of short-term ECMO runs. Based on the time of VV ECMO, based merely on the time of VV ECMO should not be a sole determining factor to stop support. Rather, we have to look at the overall clinical condition, including the presence of multi-organ system failure, and reversibility of the pulmonary condition must be taken into account. They agree that further studies need to be done to do the long-term follow-up, which actually our next journal club is going to talk a little bit about that, about post-traumatic stress and follow-up on those patients.
Absolutely, and they bring it up here too.
Yeah, they do.
In fact, there are several different points I wanted to bring up. So,
let's get to the discussion then, panel discussion a little bit. We kind of broke it up a little bit.
That's okay. I think it was great.
Yeah.
That was a great introduction. That was really a great talk. A lot of good information there. Can we loop John in? And John, what do you think about this article? And I've got some questions for both of you in regards to not just this article, but our own practices.
Yeah, this is great. Great topic again, Tammy. I don't know how you find such great topics here. You're really doing a wonderful job. And I'm so glad you went over these other research articles real quick, the ones that they, I guess, looked into or that you also researched a little bit. I think the unknown, gorilla in the room on these reasons why they're stating different survival rates, or less than 10 days, more than 10 days, is my real suspicion is patient selection. They're probably not, or maybe you're not able to really tell, what their patient selection criterias were on these several that you listed, because to find such conflicting survival rates between 10 days, 10 to 20, and even longer, I mean, reasonable logic would tell you that a longer ECMO run patients are going to have a lower survivability. I don't know that for a fact. I think anecdotally, I would say that we see that, but I'd have to look at it closer. But I think that's kind of the little bit of an explanation on some of these conflicting articles. And they do go back as early as 2011, I think you said, and as recent as 2015, which, believe it or not, in the last 5 or 6 years, I think there's been a pretty big upsurge and focus on patient selection that wasn't as accentuated, 10 years ago.
Right. I don't know if you, I'm sure you noticed this, but I don't think I highlighted this to the audience, that for this particular retrospective study, that the overall survival to discharge was 76%.
Yes, that's huge. In fact, I was just getting ready to ask that question.
And the
76%, John.
And 87% survival for the extended ECMOs. That's
Absolutely.
incredible.
It is incredible. And I think that what you're saying, and I'm so glad you just said that because it was so critically important to this, 76% for 504 days or less,
hours.
and 80 hours, and 87% for those longer than 504 hours.
Well, they had a much smaller N for that one, only 31 patients.
Well,
but
31 patients is still 87% of 31 patients, a lot of patients. That's impressive. And I don't think that's possible without being highly selective with who you are putting on ECMO. And but you know, there's some things in here that I thought were very important. And by the way, I don't know how you pronounce it. I mean, Magic is Polish, and he's telling me how to pronounce Pozluzny, but I'm going to say it like it's, well, you know what? It's Pozluzny to me, okay? I'm American. That's how we talk here, okay? But, and I actually know a Peter Pozluzny, and he lives in Vienna. He's a heart surgeon in Austria. He's been to the New Orleans conference before. Great guy, fantastic guy. Peter, if you're watching, you know, hi, just send me a message, do something.
Call in and tell us how to say your name.
Yeah. But John, I want to read a couple of things, if with your permission, if you don't mind, because I think these are very important. And then we'll talk a little more about this selection. But the longest ECMO run survivor in the study that you just went through was 4,372 hours, which was 182 days. Now, John, I know you've had patients on ECMO that long. I know you have, and we can talk about that as well. So make a little note, if you will, on that. So the patient had intra-abdominal sepsis that was complicated by ARF, or in this case, not acute renal failure, but acute respiratory failure requiring VV ECMO. The patient had multiple bouts of bacteremia, all of which were successfully treated. Additionally, the patient received a prolonged course of steroids for respiratory failure. Despite the ECMO course, the patient remained, which was very long, 4,372 hours, the patient remained single system failure, never developing renal failure requiring CRT or liver failure, and remained neurologically intact the entire hospital course. After decannulation, the patient was transferred to rehabilitation center to continue weaning off mechanical ventilation. Unfortunately, the patient passed away 7 months later, still requiring mechanical ventilation. The next two longest runs were 2,736 hours, or 114 days, and 104 days, respectively. Both of those patients are now home, off the ventilator, not requiring supplemental oxygen, and returned to pre-ECMO status. The longest published ECMO run is 265 days, although this patient was successfully decannulated. The patient died before hospital discharge. In Pozluzny et al.'s 25-year review, that can't be you, Peter, because you're too young, of the ELSO registry, the longest survivor was 2,750 hours, or just over 114 days. Two patients had longer runs, but neither survived. This is the part that I thought really got my attention. Rather than how long is too long, the more appropriate question may be, what happens to these patients after discharge? Right. That was a really a very strong point to me. And this was even stronger. How does one tell a neurologically intact, single system failure patient and their family that based on an arbitrary duration of ECMO, the machine will be turned off? The short answer to that, in this author's words, is not very easy. It would seem intuitive that a longer ICU stay and a likelihood of bridge to recovery would decrease over time. However, there is a moderate amount of literature that would contradict this notion and suggest prolonged ICU care may be appropriate in certain patients. Our group's practice is to continue care until the patient is decannulated, dies of multisystem organ failure, overwhelming sepsis, or the patient and family decide to discontinue ECMO support. So that, I think, is very, John, I don't know how you feel. I don't know what y'all's philosophy is there in Orlando. I will ask you the same question, so maybe I'll go to John first, about your philosophy as it pertains to what these authors essentially just said.
Well, I don't think we ever look at number of days a patient is on solely and start saying, well, that's just too long. I don't think we ever look at it that way. I think we look at, you know, where is this going? I think is always the first and foremost point of where we're trying to decide why are we continuing if we're not going anywhere, you know, and you can't send a patient home on ECMO. I had a discussion with a critical care physician who I think was visiting our unit yesterday and was not terribly familiar with ECMO, but had some reason to come and see the patient, so was asking me some questions. And the patient had been on now, I think it's going on 110 days or something, and the patient is walkie-talkie, but is deteriorating in almost every other way because even though they are able to get up and walk, most days they can't. They're getting, you know, the bedridden conditions, and basically, you know, there is nothing we're going to be offering this patient. He's been turned down for transplants and things like that. And so I think the first thing that happens here, Joe and Tammy, is that we put somebody on ECMO. It's kind of like getting in your car and you're going on a journey, but you don't know where you're going. You're just picking a direction. You know, you hop in your car, Joe, and you say, well, I guess I'm going to drive north and hit Dallas, but I'm just going to drive north, and I don't really know where I'm going to end up. And we do that with patients, and we go along, and then someday it occurs to us, uh-oh, we don't have a destination here. We are stuck in some way, right? We're stuck. And the physician yesterday was asking me some things, you know, well, why can't we just, you know, keep the patient like this? I said, well, you know, the number of complications waiting to happen on ECMO are so vast and so diverse that these will occur at given enough time. Right. You'll have a head bleed, you're going to have a sepsis, you're going to have more than one organ failure, you're going to have deterioration due to all the fact that you're bedridden. I mean, you're going to have what you just listed there as the reason why you were just saying the article you're talking about. You know, the patient's either going to have multi-organ failure, some type of, and if it's not a bacteremia infection, it's eventually going to be a fungal infection, which are almost impossible to get rid of on ECMO. Yeah. So if we don't take the patient off ECMO, the patient's going to take himself off ECMO in enough time because the deterioration of the body will be such that eventually the system will just clot off regardless and will stop flowing. Well, and that's eventually what happens if you
or you have multi-organ system failure. Right. You go into renal failure, they get uremic, you get them on CRT or dialysis. I guess you can treat them that way, but then they go to liver failure, their gut stops working. I think there's a lot of ways that people can declare themselves, you know, versus, you know, recognizing it and turning it off. One thing I found so fascinating about this is they did this entire study, ambulated these patients, John, ambulated them.
Before you go there, I'm going to make one comment to follow up with John before we switch gears.
Go ahead.
I agree with you completely. I don't think, my direction of this article, I really didn't think they were saying, you know, whatever the day is, 200 days, let's say. That's too many. I think what they were, the point, and I think this is where you were going with this, John, is not just, it's not looking necessarily at a time, but if they're not going to get a lung transplant and we can't seem to get them off, what are we going to do?
Well, one of the patients in this very study, and certainly I recommend people look at the title and pull this up, but one of their patients
made the decision,
was neurologically intact and had single organ system failure, his lungs, and made the conscious decision along with his family to discontinue care.
That's right.
That's got to be a big deal.
We see that quite often, Joe.
Really?
Believe it or not, it's amazing. We've had perfectly sitting up, talking, eating breakfast patients that we basically told, you are not going to go anywhere except exactly how you are in this bed, in this room, watching TV. That is the only thing that's ever going to happen. And it's a matter of time before something else goes wrong. And they can decide whether to stop or go on. And sometimes they decide, you know, within a day or two, and sometimes they decide within a week or two. But, you know, it's
how do you do that?
What do you do? Barrier that says, you know.
How do you do that, John? What do you do? I mean, I don't know that.
I mean, I guess you give them.
Do they sedate them? What do they do?
They've got to sedate them.
Oh,
right?
I mean, at the time where they turn off?
Yeah.
Okay, so that is a very good question because that is a very big and important, by the way, process, and that process has to be very, very profound. You have to
Can imagine.
anesthetize the patients very deeply to the point that they don't have that last gasp response. If the family is going to be around the bed, which almost always they are, that is the last thing we want to have happen. So I can't give you the exact, I'm not a nurse, I can't give you the exact dosages and things that they do, but they plan this out, and experience, of course, helps, where they make sure that that patient doesn't have that last gasp response, because as you know from observing that as a family member, that is
Very traumatic.
something they don't forget if that happens. So
No, I could imagine not. But I mean, yeah, I got to tell you, I don't know. I don't even know how I would emotionally manage it. To be frank with you, I don't know that I could, even though I'm Joe. But I'd be frank with you right now.
Yeah.
I don't know that I could do it, John.
That's tough.
I mean,
Yes,
I've turned them off before, but they were.
That's not the patient
were
telling you.
Yeah, I mean, somebody who was,
Caring for the patient.
Yeah.
And they
I mean,
know.
somebody who's already, essentially deceased.
Sure.
They're rotting, and there's no hope. They're completely unaware, been unaware for days.
Weeks.
I mean, I can deal with that pretty well, but this, John, I don't know how you do it. I mean, do you ever, I mean, I don't mean to ask a stupid question. Maybe this sounds silly of somebody like me in this business, but do you ever feel like, you're emotionally traumatized by it?
well, there's been a number of occasions where the director of the ICU has brought in psychologists to spend all day for a week or two with whoever wanted to talk. They bring in animals. They bring in dogs, therapy dogs for the staff. Oh yeah, there's a whole consciousness about taking care of the staff, because I mean, the nurses and the caregivers get very attached. These patients are here generally a long time. And the patients you get emotionally connected to, because, as I said, they're walkie-talkie. They're expressing friendship to you and thank you for their care, and ups and downs with emotions. And you can imagine that. So when it happens at our facility, I can't speak for others, but there's a pretty good process in place to recover the staff.
Wow. Okay, so back to, I want to get to your point about ambulating these patients, because I think that's very important.
Ambulated them with and they never used a dual lumen catheter. Every single one in this study that was done, all these patients, in this
31.
particular study, 139.
39, yeah.
Patients. And supposedly, of course, this is how they do it. So all their patients are like that. Those in the study were ambulated, but all of them were at least one femoral cannula, either femoral right IJ or bifemorally.
How do you do that?
I don't know, John. Do you ambulate patients that are femorally cannulated, and can you?
Yeah, you can. Yeah, you can, and you can. Usually it's right IJ and one femoral. I don't think dual femoral. I don't recall too many of those. But you can, and you try to, and you never with femoral artery, but with femoral vein. You look at that significantly differently, and we have ways of securing the cannulas in addition to suturing them in. By the way, we have these cannula restraints that stick to the patient. Are you familiar with those?
Oh, yeah.
They use them for Foley catheters mostly.
Yes.
Yes.
What's the name? I lost the name of them right now.
I don't know. I know what you're
Catheter,
talking about.
Catheter grips. They go by a couple different names, and they're used for Foley catheters.
But they're circular, sticky, and with like a zip tie kind of attached thing.
Yeah.
Yeah.
It's like a rubberized belt that has notches.
Yeah.
Ones we use, and we use that no matter what we're doing. We put that on every patient, regardless. Now we try not to ever put those on patients below the hip where they can bend, but anywhere else we generally put those. But if you're going to ambulate a patient, I mean it's scary and you have to take extra care. But ambulating patients is such a huge, we're such a huge proponent of getting people up and going because of what it does for them. So
can I ask you a question, John? You're going to have a lot more experience in this than I do. do you guys insert your femoral venous access particularly inferior to for that purpose, or are they, you know, right at the groin, or are they more superior? Where's their insertion?
I think
Lower,
generally it's slightly more superior as a general rule.
higher?
You wouldn't want to go inferior, I don't think. That would be more down below the bend, right? You would want to be a little above the bend, I think, but
So they go up higher. So when they
teeny
bend
bitty, I
their,
mean, you don't have a lot of freedom, I don't think. But yeah, from what I've seen, mostly you can go a little bit, a couple inches above the crease, above the bend,
yeah,
and that might buy you a little, you know, when it comes to ambulating.
because you're not going to bend the cannula
Yeah,
Right.
at that point.
right.
That's what I guess I was
But I
worried
wonder-
about, is the hip moving
Yeah,
as you're walking. And
but then I bet you're restricted on patients that might have, you know, might be obese and with their belly.
yeah, that's a problem too. But
Yeah.
now I got a question, Tammy, if I can ask.
Mm-hmm.
Just because these are the patients in the study, were they just trying to match these patients is why, you know, and I want to go over this list. Can we go to, is this, do you have a slide of this?
Table 4? Yeah.
Table 4. Can we go to table 4 on
I
the
got
slide?
it.
Oh, you have it?
Yeah, I got
Yeah.
it. Hold on.
I just want to go over this.
Yeah, okay.
So now the real question that I have is, are these just the cases, are they really this selective? I mean, age is between 30 and 54, or 34 and 50. You know, mean age is 44 to 47.
See, I don't think, remember, this is retrospective, so they
Yeah.
weren't matching anything. This is just what was
But
done.
I mean, if they only, well, okay, so I mean, if
Do you
they
know what
only,
I'm saying?
well, if they only did that many ECMOs in 3 years, that's
That
really not that
qualified.
much.
No,
That qualified.
Didn't
Okay.
have previous cardiac surgery, weren't a bridge to transplant, and weren't
Okay.
post-transplant, right? So that could eliminate a lot of them for them.
And if you notice, even on the long-term ECMOs, the E ECMO column, ventilator days was average 3.5. You know, I think that I bet ours is longer than that on a
Yeah.
lot of patients.
I mean, even their longest one is only 6.
Right.
Yeah.
Most of the time, people will keep person on a ventilator on for a while. Then when it gets up to close to day 7, when you get up beyond that critical time frame, then you make a decision to put somebody in ECMO. Don't you think that's a little more common where you guys are too?
Yeah. Well, and two, just like you said, we've made a lot of advances just in the last 5 years, and this data was from 2014 to 2017. I think we've started to limit some of those contraindicative. I mean, certainly age. I mean,
Well, yeah, I mean, I think I just want to go over each of I agree with you. So 44 and 47 respectively, short and extended. BSA 2.1 and 2. Again, for us, I mean, that's almost an emaciated patient. We don't see patients that size. BMI 33 and 32. Again, the one we're doing right now is 47. And I had to code him last night. And it was, the guy is, guy is sick. But he came back, but it was some excitement. PF ratios, I think, from what I'm used to seeing, much lower than our trigger. I mean, much lower. So the smaller patients, but far worse PF ratios than I'm used to seeing. RESP score, we were going to go over that, weren't we?
yeah, I have a whole.
So we need to go over the RESP score, which is the respiratory ECMO survival predictor. So essentially a VV ECMO survival predictor for respiratory failure.
Correct. And I'm going to go over that in detail.
SOFA score, 12 and 11. I mean, that's sick. Ventilatory days 1 and 3.5. So, was it that one was the short ECMO or runs short because they put them on at day 1, and the extended ECMO was necessary because they waited to day 3.5. I mean, is that, mean, average, or whatever? Is that the reason? The longer you wait, the longer you may be on ECMO, the more damage gets done, and it's more ventilatory lung injury or ventilatory associated lung injury. ECMO hours, a lot of hours. Prone, 55 of the patients, or 51% versus 97% on the extended. CRRT was used 47%
It's pretty evenly.
and 42%. So even steroids 54 and 71. Survival 72% versus 87% in the extended. Again, I find that to be an incredibly high number. Ours I think is pretty good, John. I don't know what you're doing out there, but I'm usually looking at, with single organ system dysfunction, pulmonary only, and otherwise reasonably healthy. 65% is really, really good. It's probably 60 to 65%, pretty close to what it was with H1N1. I don't think in our patient population we've seen that. But again, our BMIs are,
we have
our
different
47, 50 is common.
We have different eliminators. I mean, we have larger patients
And older, much older.
Much older.
I mean, to have a 44-year-old for us is very rare. We have 62 to 75.
Although we are seeing some younger patients now in
Yes,
what we're doing now.
I think so.
Yeah.
But all obese.
Yes.
They're obese. I mean, and obesity is not necessarily, I don't think COVID necessarily makes it that obesity makes you more prone to respiratory failure from COVID. But I think that if you are one of those people that have a very bad respiratory component to your COVID illness, and you are obese, your recovery course is quite complicated and likely going to include ECMO. You think that's fair?
Yeah, the obesity is not making that person get a more serious version response to COVID. It's just in combination, if you happen to have that severe respiratory response to it and you're obese, your recovery path is a lot trickier.
Or you're much more likely to die.
Yes, you are.
Need ECMO or whatever the case may be. Do you want to do the RESP score?
Yeah, let's get to that.
So let's do the RESP score. So can you guys pull that slide up?
No, wait. Oh, hold on. We got some slides to go through real quick.
Oh, we haven't done the slides?
Yeah, we haven't done the slides.
Well, you got to tell me to stop talking.
I can't tell you to stop talking. It was good stuff. Okay, so these are real quick. So this is just a little overview of understanding what the RESP score is, just in case maybe you're not familiar. I'm sure we've all heard it, but this will tell you exactly how it's calculated, and you can even calculate it yourself. Okay, so first off, this is from their the RESP website, and just lets you know that ELSO and the Department of Intensive Care at the Alfred Hospital in Melbourne developed this, and the original article it was based on, I'm going to go ahead and highlight just a little bit. This was a study that was published in the American Journal of Respiratory and Critical Care Medicine back in June in 2014 by Matthew Schmidt, and this is what, which I thought was a nice summary here. So what they hoped to gain was, increasing use of ECMO for acute respiratory failure may increase resource requirements and hospital costs. So they were trying to figure out a way to predict the survivability of ECMO. And they developed these scoring techniques from some parameters that help allow you to look at these patients, look at your resource use, allow for risk-adjusted comparison of cost center outcomes, and help clinicians target patients that are most likely to actually benefit from ECMO. Oh wait, let me go back just one more thing. Okay, it was derived from a population of 2,355 international patients. The RESP score is a robust prediction tool comprising 12 simple pre-ECMO variables. Okay, so these are the variables, the categories that they look at. They look at age, they look at immunocompromised status, mechanical ventilation prior to ECMO time, acute respiratory diagnosis group, central nervous system dysfunction, acute associated non-pulmonary infection, neuromuscular blockade agents prior to ECMO, nitric oxide use prior to ECMO, bicarbonate infusion prior to ECMO, cardiac arrest prior to ECMO, PaCO2, and your peak inspiratory pressures. Okay, so let's look at each of these real quick. Age is broken down into these categories. You can see that the left side is going to have the specific parameter that's being looked at, and the right side is going to be the numerical score that you're going to do, and you're just going to add these up as you go for the 12 parameters, and then you have your overall score. So if you're 18 to 49, you get 0 points, and then 50 to 59, -2, greater than 60, -3.
Ha.
Yeah. For immunocompromised status, what they defined it is, it's just any of, tumors, organ transplantation, HIV, cirrhosis, those types of things. You're already starting out, compromised. Your ventilation time, so less than 48 hours, you get 3, 48 to 7 is 1, greater than 7 is 0. These are the particular diagnoses that they score on. You're only able to pick one, and you can see asthma gets you the highest score, and higher score for RESP is less risk, okay? Viral pneumonia 3, bacterial pneumonia 3, and so on. You can see there.
Right, because it's a survival tool.
Right.
So you want a high number.
Exactly. Exactly.
This isn't golf.
Right. We don't want the negative number. That's not good. Okay, central nervous system dysfunction, just looking at stroke, encephalopathy. What is wrong with me?
Encephalopathy. You got me.
Yeah, no, I can't even. You can't say it either. It's
I've
contagious.
got gum.
Yeah, it's contagious.
Encephalopathy.
Seizures.
That's like snuffleupagus.
Exactly. Seizures and epileptic. What's wrong with me this morning?
Epileptic.
Yeah, that one.
Uh-huh.
This is ridiculous. Okay, some additional acute associated non-pulmonary infections, any infection that's not related to the pulmonary system, whether it be viral, bacterial, etc., you can get a -3 score. And then just the additional parameters that don't really require much more explanation. Did you get any neuromuscular agents? Did you get nitric oxide? Did you get a bicarb drip? And did you arrest? Last category is the PaCO2, and just depending on what it was prior to ECMO, gets you either a 0 or a -1. Oh, sorry, one more. And then the peak pressure, so greater than 42 or equal is a -1.
Man, I get nervous when it's 36.
I don't like it at higher than like mid-30s.
I know.
Yeah. Okay, so then you got your total score of -22 to 15. Okay. All right. Now, here's what those scores, how they calculated the survivability. They did risk class, so you can see if you're greater than or equal to 6, you have a 92% survival rate. You're in risk class 1. 3 to 5, risk class 2, and you have a 76% survival rate, which I want to highlight that overall survival rate of the article that we did for Journal Club was 76%.
That's a very good point.
It's very good.
Very good point.
So they had higher REST scores, probably. They didn't. I didn't actually see the breakdown for each patient, but they probably did. And then you can see as you go on all the way down to greater than or equal to -6, your category is 5, and you have 18% survival rate. Okay, real quick.
It's not 0.
It's not 0. It's not 0. Okay, so David, if you could go ahead and click the link, you can actually go to this website, and there we go.
Okay.
The RESP website.
Can you make that bigger or no?
I don't know. David, can you make it bigger a little bit?
No. I have to stop doing this. I'm touching the thing.
I think
with
it's
them.
maximized. Oh, there we go.
Okay.
But what you can see is on the left-hand side is going to be your survivability according to your score, and then you just fill out this little interactive chart. So, Joe, you can go in and put the age of the patient.
Okay, so we're going to make it me.
Okay.
Equal to or greater than 60.
Okay, and then the second one, are you immunocompromised? Yes or no? You just toggle that.
Okay, I'm not, so
Okay.
we're going to leave that. So mechanical ventilation prior to initiation of ECMO, less than 48 hours or greater than 7 days. So, all right, so it depends on which hospital you end up at. So I'll put greater than 7 days.
Okay.
Well, actually, they were up to 10 days, so I'll put that.
Okay.
Acute respiratory diagnosis group. So we're going to say I am other non-respiratory and chronic respiratory diagnosis. So we're going to say other acute respiratory diagnosis, like ARDS from whatever, from COVID.
Okay.
Would that be that category? I think that fits.
Yeah, I think that fits.
Central nervous system dysfunction. Some people think I have it. Acute associated non-pulmonary infection. No.
I don't know. Hey, go back and unclick that central nervous system.
Okay.
Do you see where your little red mark is?
Yes.
And do you see what
Yes.
what that associates with?
So based on these parameters,
So far.
if I have this,
Do you
my
see?
chances of survival are very low.
Very low.
So let's take that away. Acute associated non-pulmonary neuromuscular blockade before ECMO. Well, that's probably likely.
Yeah.
Nitric oxide
probably
use
likely,
before
too.
ECMO. That's probably likely.
Yeah.
Bicarbonate infusion, maybe, maybe not. But I mean, it depends. You know, I mean, let's see what it does.
It drops,
it drops you down.
Yeah, it drops you down.
Because is that because of the bicarb, or is that because you needed it?
Because you needed it.
Okay, there's the different issue. Cardiac arrest before ECMO, no. PAO. Well, let's do this. I'm so glad this is here. Let's just put it on there. I'm going to put greater than 75. And peak inspiratory pressures greater than 42. I'm going to say no.
Okay. So what's your?
Yeah, I'm going to say no. Well, no, because it might be, because we do rest settings after. This is prior to ECMO.
This is prior.
So that's not going to be that uncommon. I'm going to do it. Okay, so what's my survival?
What's your score first?
-4.
Yep. So that puts you in, let's see, what class does that put? I can't see, that's too small. I'm going to tell you the class it puts you in. Puts you in class, -4 puts you in class 4, 33.
Class 4.
33% survivability.
33% survivability. Now, let me ask you a question, because there's something else I'm going to ask you about and talk about. I'm going to take away this PCO2.
Okay.
That puts me at a -3.
You're still in the same class.
Same class.
But, you know,
okay.
it's likely that that's a less complication, so you're likely going to have a...
Well, let's make me 1 year, now I'm -2.
Yeah, so that puts you right at the edge of class 4. You're still in the same one. Really, to get like at least a 50% chance, you need a -1 to 2.
-1 to 2? Mm-hmm. So let's just say 48 hours to there. I'm
there you are.
-1.
Now you just hopped up to 57% survival.
So the difference between now, so I have a 57% survival versus a 33% survival, which is great. Now let me go do that 75 PCO2, and that knocks my survival way down.
Yep.
Just by that. So I'm glad we brought this up. So check this site out. This is really kind of fun.
This is available to anybody.
You can do this
see
very easily.
Yeah, very easy to do.
Let me see. If I'm younger, I'm a +1.
Yeah.
So you do a lot better. If you're immunocompromised, though, that's bad. Well, at 18 to 49, it's not too bad.
Age is, I think, really your
asthma,
biggest helper.
Asthma moved me way up. So if my problem is asthma, I'm in so much better shape. If it's, let's see, how about viral pneumonia? You're still a 3. Bacterial pneumonia.
You're in good shape
about
still.
the same. Non-respiratory and chronic respiratory diagnosis 0. So really, this other acute respiratory diagnosis, well, that's still a 1. So actually,
it's all the factors. I think,
and it's the age too.
The
age goes from +1 for the next age group to -1 to -2, just based on age.
And that's just to greater than 65. Like this is probably
greater than 60.
Oh, sorry, greater than 60. So if you think about, I would like to know the relationship to the higher rate. I mean, we've got several decades that we're seeing. You know, what's a 70-year-old versus this? What's a 75-year-old?
Yeah, because I mean, you know, look, we were doing octogenarians in 1987 to 88 doing coronaries on octogenarians. They have done them now on centenarians. and have done the surgery, done coronary successfully.
So this is
I
probably,
mean, that's amazing
this
to
technique,
think about
I mean,
it.
this tool is really, it's fascinating, but I bet we have some updates, especially after all the ECMOs that we're doing now.
But then do you use this just as, because you have to always do the eyeball test, right? You can have this score, but if you're looking at the patient,
Yeah.
and I mean, who and how I hate to use the term, but do we know the accuracy of this? How valid is this?
Well, I think it's used pretty, I think a lot of places use it. John, what about at your center? Do you see people referring to this score?
Yes, we use it all the time, but we use this in combination with, as Joe was just saying, all the other clinical factors and the patient factors. You have to use it as a tool. It's a pretty important tool, and we definitely use it on every respiratory patient we run a respiratory.
Well, I was just surprised it was so, you know, I've read about it, but I've never actually tried to do it myself, and I just love that it was so easy to do. You really don't have to have a lot of skill to be able to just check those boxes, and those are things you'd probably know about the patient pretty easily. So even as a perfusionist, you could, you know, go to this website and kind of figure it out and just kind of know where you are.
Well, that's like the STS risk calculator for surgery. I mean, we do those.
Yeah.
And you can get the app on your phone. It's so easy to do that. In fact,
By the way,
I don't want to add that to our thing.
Oh, yeah.
By the way, Joe, this does not have an app. They have not created an app for this. You have to go to the website.
Yeah.
So
really?
There's a need. There's a need
There's
there.
a need.
Oh, we need to, Magic,
Are you listening?
we need to do an update, bud.
Oh, you'd have to figure out the algorithm, but that wouldn't be that hard, I wouldn't think.
No, I don't think so. I don't think so.
But anyway, that's all I have.
So I want, well, before we go, don't take that away.
Oh, okay.
So don't take that away. So John, I want to go over this with you. I'm using the wrong mouse. Okay, John, I got a question for you. You can see here I'm a -2. When I put this PCO to it, I go to a -3. So if I were in better shape, let's say I'm a -1, 57% chance of survival. Now I have a 34% or 33% chance of survival off this PaCO2 of 75. Look, the thing that I wanted to bring up to you is I went to a hospital to help them with some ECMO. And, you know, we, in our practice, of course, I was in there, I was helping them, right? So, you know, sort of when in Rome, you have to do as the Romans. And I wasn't there to change their practice. And they were doing so many cases, I mean, a lot. I had 16 at one, no, you have 18, you beat me, but I had 16 in one day, to take care of at the same time. And no ECMO specialist. I was there by myself. It was rough, man. I mean, you're just holding a lid on it. But I kept noticing all of the labs on ECMO where the PCO2s, they were preferentially weaning the sweep versus the FiO2 on the oxygenator for weaning. And every patient, no one had a PCO2 of under 70, and no one, and the highest I saw was 110 for days, and 90 was kind of normal. And all of these people had been respiratorily acidotic for so long, permissively, that their bicarbs were 48, 52, 56, 47, 45, 51. I mean, I've never seen anything like this before. And, and I really, well, I'm going to ask you, since I think you have more experience with this. You can take that but I just wanted to point out that that's on this and seems to be pretty. I don't know if this translates from pre-op to keeping it like that post-op. Intuitively, we would never run a CO2 that high for cerebral perfusion issues and some other things. But with your experience and your knowledge in this, can you give me some Give me some feedback on that. You can go ahead and take that slide down, David.
We're done with the presentation, David.
Thank
Thanks.
you.
Yeah, wow, that's interesting. I have been a lot of places. I haven't seen that, but there's a lot of things to unpack there. But let's start basic physiology first. Anybody who runs a NIRS or CASMED or whatever you do on your cerebral ox for, let's say, your regular routine bypass cases or ECMO, but let's just say a lot of our listeners, they may use it on their routine bypass cases. You notice right away that if you keep your CO2s normal, let's say 40 on your arterial blood gas, that whenever you have difficulties with your cerebral oxys going too low, what's the first thing you do? You let your CO2 come up to 45, 48, 50. In fact, people that do these routinely just start running their CO2s somewhere between 45 and 50, which, as you can tell, for people who do this, has a pretty powerful vasodilatory effect because it works. And if increasing your CO2 to 50 or so doesn't work, then you have to start increasing your flow or adding blood, right? And so that's what happens with these things. And people who run these learn that a lot. So the opposite also happens in the lungs. When you have a high CO2, you have vasodilatation in the cerebral vasculature, and you have vasoconstriction in the pulmonary vasculature. So that's what you have to remember. So fast forward to what you're just now talking about. We do try to push people off ECMO. You try to push them off, and then what that means is you wean the sweep down, and if you can live with a PCO2 of 55, 60, maybe even 65 is our limit, and just to be able to get them off ECMO, if they can sustain themselves, oxygenate themselves okay, and adapt to a CO2 of about 60 or 65, we may take them off, but we don't push it any further than that. So we've never seen what you're talking about, but let's just go back to what I was first saying. If you have a bypass patient and you increase your CO2 to 50, you see a pretty good, significant cerebral vasodilatation. I can't imagine what it is at 80, 90, 100, 110 or something. So you're going to have maximum vasodilatation in your cerebral perfusion. That has to lead to an increased incidence of cerebral edema at the very least. Now,
at the very
I don't have any
least.
statistics on that.
At the very least.
You think you saw that there?
No, I saw several cases. Now, I think you may have seen the same thing. I don't know if there's a direct correlation, but I saw what was, in my view, a much higher incidence of cerebral hemorrhage, devastating cerebral hemorrhage, actually, than I've ever seen in our own practice. Now, there was a lot more patients at one moment, but these were relatively young patients. We've certainly had some who have experienced that problem for other reasons, but the percentage the number I saw seemed unusually high, bothersomely high to me.
I just don't, I guess I'm having trouble understanding why you would do that for days and days, because that's what you're talking about, right?
Yes, and I will tell you what they told me.
Because I get what John's saying. Sure, if we're close, we think we can come off ECMO, or we'll accept CO2s a little higher because of course if we can get them off and they can sustain at that's good, right?
Agreed.
I just don't understand so many days, and like you're not really weaning at that point.
Correct.
Right?
So what they told me was that they believed, this is what they said to me, that they believed that these patients were going to have to live in this very
all COVID patients, right?
Yes. Okay. In this very hypercarbic environment, that their physiology was going to be this, and that the only way they could be weaned from ECMO was to permit their PCO2s to go that high and stay there that high to allow for the metabolic compensatory mechanism to factor in, and their pHs were 7.32 or above. So they treated the PCO2 based on the pH alone. So if the pH was 7.34 or 3.5, and the PCO2 was 50, they would turn the sweep further down to allow for the pH to get to 7.32.
Okay, I see.
And allow the PCO2 to continue to climb. But I was like, well, wait a minute. You're not on full ventilatory support here. They're tidal volumes of what they're going to breathe if they're not on that ventilator, or if they, but their argument then was, well, we don't plan on changing their ventilatory settings. They're going to continue to be on these ventilatory settings because their lungs are going to be too stiff, and they have to learn to live with this, to be off ECMO.
Okay.
Now, they may be trached and still on a vent, but I guess off ECMO and still alive.
How do they
It was very
determine this?
bizarre.
What are the patients that they selected? Every patient? Every COVID patient?
They put everyone went on ECMO.
So
There was no, it was indiscriminate. There was no.
Everyone had high CO2s. There was no particular factors.
There was not, no. Everyone was, their vent settings were reduced to a bare minimum. And
like
the
40%
sweep,
or?
well, no, they would go down to 30% on the vent as FiO2. It was the volumes.
Oh, the
They would-
volumes. What
they
kind
would
of
keep
volumes?
Very low. I mean, very low, like
Right.
180, 200,
Oh.
in that range. Very low.
see.
yeah, I don't see this working, but they need to write a paper and do a study and
That's
teach
what
us,
I,
because I'll tell
I
you
thought that
the other
too.
thing-
I'd love to read it.
I'd like to read it too. Well,
Yeah,
it's interesting
here-
because we have had
here-
patients that, I mean, the CO2s might have been slightly higher, but we've gotten them off ECMO and they've survived.
Yeah, it's 60.
Yeah,
I mean, I may have seen that. I haven't seen much over that.
yeah.
Right.
But I mean,
I haven't.
but I'm just saying we've had success rate not doing that, so
Well,
it's interesting.
There is something that I thought was very interesting.
I cut John off. I'm sorry.
Oh, sorry, John.
Well, the
So-
reason, give me one second, Joe. The reason why I was saying I don't see this working, and I'm not a doctor, I could be wrong. And Timmy, you actually made mention of this about 10, 15 minutes ago on something you said, that on one of the things you're referring to, that patients with RV dysfunction, they kept the PCO2 between 35 and 40. I don't know what you were referring
Yeah,
to,
it
but
was
I
the
have notes here
original.
on that,
Yeah,
right?
the original
You know what I'm
article
saying
that the REST score was created from, that was published in 2014. Yeah,
That had the PCO2 of greater or less than
yeah.
75
They
preoperatively,
No,
pre-ECMO.
no,
It
no,
was
no. When
before
they're
that.
talking about their the original paper. Yeah, their parameters, their established parameters for ECMO. If you had RV dysfunction,
Right.
you, instead of running 35 to 45, or
Right.
then it was
Right.
30 to or 35 to 40. It was a
Right.
lower
Right.
range.
And that was what you just said, John, because
Right,
you
exactly.
don't,
So this is
45
my
is
point.
enough to cause some pulmonary vascular constriction, which is a problem.
Yeah, correct. So this is exactly my point. So these people are telling you, if you have RV dysfunction, you want to run a lower CO2, which is going to give you pulmonary vascular vasodilatation because of your RV dysfunction. It's already there. But back to the story now. How are they going to get this patient off ECMO, and the patient is going to be able to breathe room air and have such enormous pulmonary vascular constriction and still be able to oxygenate themselves?
I'm looking for the paper.
Yeah. So the other thing is that you have two other things that go on here, may or may not be overwhelmingly significant, but you have cellular enzyme dysfunction with this high of CO2 levels and an acidosis of 730, even 732, and also with being on ECMO like this, the effectiveness and the reactivity of your pharmacological agents are going to be different. You're not going to have the same exact effects, so they're probably able to work around that. But all I'm saying is, you're trying to turn the ECMO off and rely on the patient's ventilator status, and you have a vasoconstriction, a pulmonary vasoconstriction that's got to be so severe. And you just said to me, Joe, a minute ago, that their tidal volumes are 180 or something, right?
Yeah, they're way too low. But that's
Right,
what
they
they
got to
want,
be
because that's what you
450,
need.
500.
You need to have rest. You have to have rest lung settings, right? The whole idea is to not have barotrauma. So, if your lungs are stiff, but how much is the PCO2 contributing to this stiffness? Look, I'll just take a show of hands, okay? I'll do it. We'll just ask a basic question. In my view, I think that when we put somebody on ECMO, whether it be VV or VA, within the limitations of the mechanical systems that we use, and cannula placement, maybe there's body habitus issues, maybe there's, you know, other anatomical considerations. But within with those limitations in mind, my goal is to make the patient as physiologically normal as I possibly can.
While resting.
Yes, their labs. I want everything to be normal. Do you agree with that?
That's what I do.
Yeah. Okay. So I think that's something. I'd love to know what other people think about that. I wanted to point this out. So, hey, John. John's back. Good.
Okay.
So, John, I asked a question. I don't know, did you hear me? Your sound is off.
Yeah, I just got to take a quick call.
Yeah,
Go
that's
ahead,
fine. No, I'm sorry. So what I said to Tammy was, and she agreed with me, notwithstanding the limitations that are imposed by the mechanical systems that we use, cannula placement, perhaps anatomical considerations, body habitus, et cetera, et cetera, et cetera. My goal when somebody goes on ECMO, VV or VA, doesn't make any difference, is to achieve as normal a physiologic state as I possibly can. That's pH of 7.40, PCO2 of 40, PO2 or arterial saturation of above 95% or 92% at least. And that's my goal. But I needed to ask a question because John's busy. If you breathe 5% CO2, 95.5.
Okay.
You've seen a tank of 95.5? Have you ever breathed it?
No.
Okay, well, when I was a student, I was forced to breathe it.
Okay.
So, hey, John, if you breathe 95.5, how much do you think it increases your cerebral blood flow?
Probably quite a bit.
50%.
What?
If you breathe 7%, 93.7, 7% CO2, how much do you think it increases your cerebral blood flow?
75.
100%.
Oh my gosh.
Doubles it. So I believe if you have a PCO2 of 80, 90, 100, that you are basically flooding the brain, causing all kinds of cerebral edema, and eventually I think it leads to neurologic deficit. Whether it caused the cerebral hemorrhage or not, I can't really say, but I certainly think it causes a tremendous amount of cerebral edema, which will, of course, lead to neurologic dysfunction in my view. So, John, you probably still didn't hear me from earlier.
Yeah. Well,
do you try to run your cases to achieve the most normal physiology you can, given the limitations of the systems?
Right. You try to let the ECMO do absolutely all the work until at such point it's doing as much work as it can, and then you have to start asking the lungs to do more work and turning up the vent, which you really don't want to do.
But the key is to reverse the lung injury. Right. Whatever that lung injury is, stop them from becoming fibrotic.
Well, I guess
treat the underlying illness.
I have trouble understanding why you wouldn't want to give the patient the best support you can give them. They're sick, you're resting them. We have a machine that can do this for them. So I have trouble grasping.
You have trouble grasping. I had trouble grasping.
I mean, in theory, let's just say in theory, you can understand where someone might go along that kind of thinking. Okay, well these
don't.
Well, just hear me out. Just
okay.
on the surface, these patients, they don't think are ever going to be, to full capacity again. So what can we do to be able to help them adapt to the way they're going to have to live? So on the surface, that kind of sounds like a line of thinking but I don't know how you could know that about every single patient, because not.
I don't think you can. I think you make the patient physiologically, homeostatically neutral. You create a homeostasis that is compatible with life. You treat the underlying condition, whatever it is, hope whatever the issue is reversible, right? Try to figure out the best way to treat it if it's COVID, to keep the lungs from becoming fibrotic, which may be the dexamethasone. I don't know if it is or not, but the high-dose dexamethasone seems to be beneficial in helping to prevent that from happening. And then, you know, over time, as you continue to get, you know, you get the vent down, you slowly, what we do, slowly start, we go with FiO2 way before we ever consider the sweep. If we can get the patient to a 40% on the vent with a, you know, with peak pressures not exceeding, let's say 30, maybe 32 at 32, the very 33. Most. Really, we like 26, but we accept sometimes, depending on the size of the patient, right? Most of ours are really big. They got a lot of weight. They're going to have a higher pressure. And then once we get our ECMO to 21%, we start bringing the sweep down and see how they're going to respond to that. So we bring the sweep down based on their ability, the FiO2 on their ability to oxygenate, the sweep based on their ability to ventilate. But
that's the basic concept of bypass anyway.
And I think that's what the published data says about how you should do this. See, I think there's a plethora of data that is, for someone who wants to embark on an ECMO program, can use, and ELSO is probably the gold standard. I think ELSO is the I think you should follow ELSO guidelines. Yeah. That's what I think you should do.
Yeah.
Okay. Final thoughts?
So,
Candice Baracino?
What do you think about the future? This is just something I'm musing about the future of development of some kind of something for these patients that are in these, you know, acute, that become chronic respiratory failure, can't get a lung transplant, are only in a single system failure, some kind of VAD ECMO portable permanent device. Have you read anything about that?
Not really. I think it's a real challenge. I'm going to punt that one. I don't think I could answer it. John?
Well, I wanted to leave you with a couple final thoughts on a paper that I found, published in 2019 in Kaiser Health News, and it's kind of interesting. It says, miracle machine ECMO leaves patients in limbo, which is kind of what you guys were talking about at some point, as how long is too long, right?
Yeah.
So, you know, there's just three quotes here from the various physicians, and actually one of them is Dr. Bartlett, so I thought it was important to hear what they had to say. But, you know, ECMO can become a bridge to nowhere, leaving patients in limbo, possibly awake and alert, and but with no chance of survival outside the ICU. Medical teams and families can be fiercely divided over when to pull the plug. Well, that was just kind of an intro statement. But then later, there's an expert by Warridge, who also is concerned that ECMO affects organ donation. In other words, if you put somebody on ECMO, now they go to the top of the list of receiving an organ donation. So that's something
lung transplant.
That is interesting. And then here with Dr. Bartlett, as you know, pioneer of ECMO and a teacher of many ECMO physicians, he says, quote, we should always tell the family, hey, we talked about futility and now we're there. So we're going to turn the circuit off tomorrow. It's extremely discourteous to the family to ask the family what to do. And then in Boston, Dr. Daniela Lamas, a critical care doctor at Brigham and Women's Hospital, she has something interesting, quote, too, and she says, you know, ECMO, she said, is a fantastic example of just because you can doesn't mean you should. Yeah. So I thought I would leave you with that.
Yeah.
Can you do me a favor? Would you send me those 2 citations, dude?
Yeah.
Yeah, I'll send you the email you the article if you want.
That's really
that'd be great.
I would love
like
that,
it too,
especially
John.
the comment from Dr. Bartlett, because that is such a conundrum we find ourselves in all of the time here, is that, you know, it's clearly futile.
Well, and especially at our religious hospitals, I think it becomes even more of a problem because they really do want to leave it to the family. And you know the patients that we're talking about. We're not talking about the most of the patients. We're talking about the ones that we already know.
Yeah, I mean, you do.
And then now it's put onto the family. I mean, we've had that happen very recently with very young members, lost a parent. Now they're about to lose the second parent, and they're basically barely legal adults, and it's been put onto them what to do.
Yeah.
That's hard.
That is, and I think unfair.
I think that's
agree with
interesting that's what he's saying.
I agree with Dr. Bartlett in this
too.
case.
Yeah.
I do too.
It's on one hand you think, well, we're doing something very humane by asking the family what they want, but in reality, that really is probably not the case at all. We're burdening them with an enormous decision of which they are not really capable of understanding the gravity of the situation.
Well, I think too, they really just, most of them, no matter how many times it's explained, they're in that emotional time with their family member, and it's hard to explain that the ECMO in particular is not fixing anything.
Right. It's not curative.
No.
It's supportive therapy to buy you time to treat the underlying condition that is causing the problem.
Right. So I think a lot of times they're faced with do I give up? Well, this isn't a give up kind of situation. It's we did everything we could do, but the patient wasn't able to recover. Yeah, so blame the patient. The patient just wouldn't stop. The patient wouldn't stop bleeding. The patient just would not stop. You got to blame it on Grandpa. Come on.
Guys, one last thought. I'll let you go, I guess. But when I wore a much younger man's clothes, I was in my first few years of perfusion, and as you know, in the 80s, ECMO was horribly unsuccessful.
Was that any clothes, John?
Single digits or something.
It wasn't the 60s.
But anyway,
John, were you wearing any clothes?
Yeah, when I wore a much younger man, perfusionist clothes, right? And I never forgot this. It's 2 or 3 in the morning, and it was just left to me and the nurse. The surgeon said, just, John, do whatever you need to do. I'm going home. There's nothing I can do. So we're talking to the family, and I'll never forget this. One of the greatest things I ever heard a nurse say to a family member and consoling with them, because it was completely over. And she said to the family, they're all grouped around the patient wondering what's next. And she said, God is calling your loved one home. We are standing in the way. And they accepted that and felt so much better about what we were really doing. We're not reversing anything. Right. We are just stopping what someone far greater than us, powerful than us, already has said was going to happen.
Wow, that's prophetic. Yeah, thanks for sharing that. Okay, I think we ran over a little bit. I hope nobody minds. You don't get extra credit for it. The board pre-approves these, so when we're short a different day, you still get the same credit for that too. So we may have to make this up a little bit somewhere along the way. We'll see you all on the 17th.
Next Thursday.
Yes, next Thursday. It's an evening program to accommodate the people on this side of the pond and so forth, so more in the U.S., but for those of our European partners that may be watching or want to watch then, because it's going to be another really good one, please tune in. I don't know it's going to be very late, but we'll try to be on time and end on time as well. We'd like to hear from you all too. So thank you all very much. Tammy, once again, thank you so much.
Thank you.
It's always a pleasure. John, thank you
John.
very much. Both of your guys' knowledge is so incredible and powerful, and I learn a lot from both of you all of the time, so thank you. And we'll see you all on the 17th. Be safe.
Have a great day.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.